Good morning, everyone, and welcome to the Grand Round today. Today is our third Global Surgery Grand Round for this year, and we were very ambitious in organizing 3 speakers for today, be it half-term. But you know one of the speakers very well, which is Chris Lavey, and I think whatever he has to say is going to take the entire Grand Round, so we've decided to defer his talk for next week. We've chosen this topic of FGM because it's quite a political discussion taking place in parliaments. Councils are talking about it. School children have been primed about this. And even in our mandatory training, it has been brought to our attention that this is an issue that we need to think about and tackle. We also have some members of staff from the safeguarding team, so it's welcome to the Grand Round. Without much ado, I'll introduce the first speaker, who is Anita Makins. Anita is one of our consultant obstetricians and gynecologists in this trust, and she's also the director of FIGO, which is the International Federation of Obstetricians and Gynaecologists, which is based in London. She has a master's in public health, and regarding this topic, she's currently lead of a Rose clinic that is run in Oxford for patients who have suffered through this kind of cultural action. The second person is, and Anita will give us the global perspective of this condition. The second speaker is Dr. Katy Newell-Jones. She has a PhD in education, and she's been in education for the past 30 years. She was awarded a lifetime award for National Teaching Fellowship by the Higher Education Authority in 2004. Regarding this topic, her attitudes and beliefs and practices associated with this condition began in 2009 in Kenya, and then she extended this work to Tanzania, Somaliland, Sierra Leone, and Liberia. But presently she's working with 2 NGOs and is connected to the WHO Reproductive Health Desk regarding FGM. So without much time, Anita.
Okay, so I'm going to talk to you about female genital mutilation or female genital cutting. It's going to concentrate on giving you a bit of a global perspective and sort of introducing Katy's talk, where she will go into detail about the sort of socio-cultural aspects of it. But I thought it was important to just make sure that we all kind of understand what FGM, FGC is, and also where we stand at the moment in the UK. So the definition of FGM, FGC is any procedure involving the removal of the external genitalia or other injury to the female genital organs for non-medical reasons. So the WHO classifies FGM into 4 different types. So the first one is type 1 FGM, which is partial or total removal of the clitoris and or the prepuce, so just the skin overlying the clitoris, also known to, when you remove the clitoris, as a clitoridectomy. FGM type 2 is a partial or total removal of the clitoris and some of the labia minora, with or without excision of the labia majora, although I think that's much rarer. FGM type 3 involves narrowing of the vaginal orifice with the creation of a covering seal by removing some of the labia minora and then actually stitching the remaining parts together. So there's apposition of the labia minora and or the labia majora, and you can have excision of the clitoris with that or not. So it involves sort of closing up the vaginal introitus as well as the removal of some of the anatomy. And then type 4 is really anything else that doesn't fit into types 1, 2, or 3. So any other harmful procedure to the female genitalia for non-medical purpose. So examples of that might be pricking, piercing, incising, scraping, cauterization. We've also recently seen elongation. of labia minora or majora. So here are just some diagrams of what we're talking about. So type 1 FGM, you can see on the top right, the little red area would be removal of often just the prepuce or sometimes some of the clitoral gland underneath it or all of the clitoral gland. Type 2 here, so removal again up on the right, and the red is the area that's removed. So removing either just the prepuce or some of the clitoris, but then also some of the labia minora. And the bottom right is how you would see it sort of years down the line. So as a woman, you would see scarring as sort of anterior superior portion of the female genitalia. And then type 3 involves removal, or usually removal or cutting of sometimes the clitoris, also the labia minora, but then importantly the stitching together of the opposing remaining genitalia, so that there is not complete closure, but almost complete closure of the introitus, so obliterating the external, the urethral meatus, and narrowing very much the vaginal introitus as well. So as you can imagine, the consequences of FGM or FGC will vary very much depending on which type the lady has undergone, whether it's a type 1, type 2, type 3, or type 4. But some of the table shows some of the consequences. So physically, obviously at the time of the surgery, they would have a lot of pain. The clitoral area is a very vascular structure, so quite a lot of profuse bleeding at the time of the injury. Usually, people who remember having it done will describe difficulty or pain when passing urine, because it's all very stingy areas, you can imagine. And then if they've had a type 3, so actual closure of the introitus, then they'll have difficulties with menstruation, sometimes difficulties with passing urine, so not describe sort of normal flow. And then obviously for intercourse and also vaginal birth, they often will require de-infibulation, so an opening up of the introitus which has been stitched together. Psychologically, so depending on when the lady underwent FGM or FGC and her memory of the event, then she may indeed suffer from traumatic memories, PTSD, and so on. Sexually, obviously, sometimes inability to have sexual intercourse at all if they've got a very severe type 3 FGM, so they would require de-infibulation. And often describing dyspareunia, so on intercourse, superficial pain with the scarring that's left, even with type 2 or just type 1 FGM. And if the clitoris is removed, then anorgasmia as well will be a consequence. So who's performing this? Well, again, across the globe, depends where you are, who would be involved, but this can go from quite a medicalized practice in some countries, so doctors, nurses, or midwives doing it in hospitals, to nurses and midwives doing it in their own practice, sometimes at home or within villages, to traditional birth attendants doing it under sort of less, obviously, sterile conditions in rural areas, or lay women who, within that village, it would be their responsibility to do the female ceremonies, which include a circumcision. So then we listen to all of this and think, why on earth are people practicing this? And Katie will go into the complexities of it in her talk, but in some cultures it's culturally accepted as normal, and that's what's expected. Part of a coming of age process, so part of these women's ceremonies. In some cultures there is a belief that it would reduce promiscuity or unfaithfulness before or during marriage. And also in some countries it ensures maritable suitability, so a lady is not able to be married unless she's been circumcised. So really important sort of step towards growing up, if you like. So this is an interesting picture which I found on the internet, but it's called Dancing Girls, and it's a picture taken in Sierra Leone in 1910. And it's a picture of the girls who have undergone their secret society meeting. And the ladies on the right and on the left wearing the masks will be the ladies who were in charge of the ceremony. And if you have a look at the one on the left there, so this is a photo which I took 100 years later when I was in Sierra Leone working for MSF. And you can see the mask on the right is identical to the mask on the left here of the picture that was taken in 1910. So in Sierra Leone, I just thought I'd give you an example. This was where I first came across FGM, FGC. It's part of a ceremony where girls take part in a secret society. This is something that their parents decide that they then go to. The ladies with the masks on, they're actually called devil masks. And the ladies are in charge of the whole ceremony, which will involve a lot more than just the cutting, just the FGM or the FGC. It will involve trying to explain to the girls what it will be like when they grow up, what menstruation means, what their duties would be as a wife, what their place is in society as a potential future mother. It's quite a matriarchal society, Sierra Leone. So the girls sometimes would be very excited towards, having this ceremony. They go in, they disappear off into the forest. The families will give them lots of food to survive several weeks and so on. And they dance and they sing and they sit around fires and they talk about what it's going to be like when they grow up. And then as part of this big ceremony in Sierra Leone, FGM or FGC will be performed as part of that act. But when we say, why do we do it? So 100 years down the line in Sierra Leone, they're dressed in the same way and doing the same practice. And again, this was the photo. So that lady was in charge of this group of girls who would vary in age. So I think since the Civil War, the age at which girls would take part in the ceremony has gone down. And I think that's been a trend across many sub-Saharan African countries. It doesn't necessarily mean that they are going to be married immediately after their ceremony, but it's part of their initiation into the realization that they're growing up and that they are going to leave their original families. So globally, about 200 million women have undergone FGM in the world today. These are estimates from UNICEF and UNFPA, and I must say it is very, very difficult to get accurate data on FGM and FGC prevalence and practice at the moment. So you need to treat the numbers with a little bit of trepidation. So the half of these are actually in Indonesia, Ethiopia and Egypt. And that doesn't mean that it's super common in Indonesia, Ethiopia and Egypt, but actually they've got a large populations and a large proportion of those women have undergone FGM. So it's known to happen across 30 countries, Africa, Middle East and Asia. And there's an estimate that about 3 million girls are at risk of undergoing the procedure each year. So again, bear with me with the stats because it's very hard to find good statistics on this, but there's thought to be sort of a band across the centre of the world where there are countries which are involved in practicing FGM and FGC. So in green there's the never, and then as you go through to the yellow, orange, and then red is more than 50% of women have undergone FGM. So you can see there Africa and some Southeast Asian countries. So this is probably the more scientifically sound data that I've come across. It's a systematic review, and it's using demographic health surveys and mixed data, sort of pooling them together and trying to work out if there are regional trends and what's happening over time with FGM and FGC. So you can see there, if we look at the right-hand column, we're looking at the average annual percentage changes from the first survey that they looked at, depending on what was available in each of those regions, to the last survey that they've looked at. And so in Central Africa, you can see there quite a small number of surveys, so only 4 surveys starting in, the first one was 2004, and then they're comparing it up to 2015. And you can see there, statistical significance not great, so we don't really know what's going on in Central Africa, but likely to be sort of static in terms of any change. East Africa, you can see there 13 studies looking from 1995 to 2014. So you've got there fairly good evidence of a decrease, minus 7.3% of average annual trends in circumcision happening. North Africa, again, 9 studies, so minus 4%, so also decreasing trend. West Africa, good number of studies, 17 studies, and also a decreasing trend. So a general understanding that in Africa, at least, it is a decreasing in practice, or has done over time. And then in Western Asia, they're difficult to interpret. There's only 3 studies, and it's actually only covering 2 countries. But it does say there's an increase. And if we look at this graph, which is drawn from that table, You can see the pinky purple line is Western Asia. So just a caveat on that, because it only actually includes 2 countries, which are Yemen and Iraq, whereas the information on Africa is much more widespread and the surveys are much larger, so probably much more significant. But generally speaking, a decreasing trend in many places. And the countries with the highest yearly average, so you've got there Mali, 73%, Eritrea, 67%, Mauritania, 61%, Guinea, 50%, Djibouti, 49%, Somalia, 46%, Sudan, and there's a table there. If anybody's interested, they can go back and read it. So why does it matter to us, or why does it matter to UK practice? Well, it does matter a lot because of immigration, and a lot of these women may be living in the UK, so it's knowing how to deal with them. What are their needs? Are there any needs? What are they, and how best to deal with it? And importantly, it became a very, as Kakila was alluding to, it's become a very politicized subject. And there was a Female Genital Mutilation Act which came out in 2003, which said that it was an offence to carry out FGM and that it carries a sentence of up to 14 years. And so far to date, there's only been 1 conviction using this act. But importantly, there's other reasons that people can go to jail other than just if they carry out FGM. So offence to assist a girl to mutilate her own genitalia. It's an offence to assist a non-UK person to mutilate overseas a girl's genitalia. And then lastly, which is what a lot of the parents that come to the clinic in Oxford are worried about, is that it's an offence to fail to protect a British national from having FGM even when outside the British territory. So what that means is that if a parent has a British-born child and that child goes back to their home country with their grandparents or stays with their grandparents and undergoes FGM, when that child comes back to the UK, her parents are liable for what happened to her in the country that she left to. So, you know, really quite punitive law at the moment. And then I just put at the bottom there the FGM enhanced data set. Claire Robertson's one of the paediatricians who is in charge of the safeguarding and so on of the girls. But just to say that the government does have a data set, and women who come through the FGM clinic, we ask them whether they're happy to be on the enhanced data set, although the government says this isn't deemed necessary. But there is a form of collecting data on these women, and this is also a big controversial area because a lot of women may not want that kind of information to be wildly discussed, or even though in theory it's anonymized. So quite sort of strict laws and monitoring of what's going on in the UK at the moment. And again, just to give you a pointer if you're interested in reading more about it, so more recently there was an article in the BMJ by Sarah Crichton, who does a lot of the FGM work in London, talking about how we're tackling FGM at the moment in the UK, and is it actually the right approach, this very punitive strict management of what happens to a lady with FGM in the UK. And then there's been quite a bit of back and forth about whether actually the evidence that we have supports whether we have sufficient evidence about FGM statistics in the UK to be doing what we're doing, and whether we have evidence that what we're doing at the moment is actually beneficial to these women, or whether actually we may be making things worse. So to tell you what happens in Oxford, so Brenda Kelly, who's unfortunately not here, founded the Oxford Rose Clinic here at the JR, and I'm running it at the moment. So it's a monthly clinic, it's multidisciplinary, so we have a specialist obstetrician and gynaecologist, which would be myself or Brenda, a psychosexual counsellor, stroke general practitioner, and also a clinical psychologist. And the clinic is set up to deal with health issues associated with FGM for pregnant women, but also for non-pregnant women. So we try and see the pregnant women more urgently, because as you can imagine, if they've had FGM type 3 and it's an issue for delivery, then we need to de-infibulate the ladies before they go into labour. But we do see a lot actually of non-pregnant women who either just want to find out what they have or what it means to them, or if they actually have consequences from it and need some support with that. So it's an opportunity to educate, and hopefully we try to instill a sort of measured and appropriate response to each and every case, because it varies. As I've tried to give you an idea of what's happening sort of across the globe. You can imagine sitting in a clinic getting people from all over the world. Actually, one person's experience, for example, in Indonesia might be very different from another. A Sudanese lady, so a lady with the type 1 from Indonesia to a type 3 from Sudan will be a very different experience and need a very different management approach. So we offer also prenatal defibrillation, as I said, for the pregnant ladies. So this isn't statistics. I mean, I'm sure Brenda is looking into the numbers, but this is just based on my experience of the ladies that we've been seeing. So the reason that they're referred, well, the main source of referral to the Rose Clinic are midwives who see ladies antenatally when they do their booking appointment. One of the questions that they have to ask the woman is, have you suffered from FGM or FGC? And if they say yes, then they automatically get referred to the Rose Clinic, and that's standard. So vast majority, a lot of women are referred through that route, or there can be self-referrals or GPs, obviously, if women have had issues. So as you could expect, the DNA rate is quite high, about 30 to 40%, I would say, something like that in terms of DNA. And this may be several-fold, but I think the punitive nature of legislation in the UK definitely contributes to this. Women do not want to come and tell come to a clinic to talk about FGM and FGC if they don't have a problem with it and they've heard that it's something that the government is collecting statistics on, then they don't want to come to clinic. So our DNA rate is quite high. I'd say the vast majority of women who come do not perceive it as a problem. So the vast majority that we see are type 1s and type 2, and they often have no memory of the incident because it was done as a child, so before the age of 4, in some countries actually as babies. And they don't have any sequelae from it. They don't really see it as an issue. It's something that happened to them as part of their culture, but it's not a problem at all. To say that type 1 and type 2 FGM can often be missed. So often people will have had reasons to have other examinations prior to coming to the clinic. So, for example, for a smear and so on, and no one will ever have commented on the fact that they have FGM because it can be quite subtle. The scarring can be quite subtle, particularly if it's just a type 1 or if it's a mild type 2. So sometimes you have women coming and saying, well, no one's ever mentioned this to me before, why has it now become an issue? And they might have been seen by multiple health practitioners who haven't necessarily picked up on it, even though they've had examinations. So continuing about the women, so there's a proportion of women who will report anorgasmia and dyspareunia, particularly prior to their first birth, to their first parturition. They often describe that improving after the first birth. And there are a small proportion who obviously do remember the incident, so particularly when the FGM or FGC is performed later on as an adolescent or as an older girl, they'll remember every single detail of that event and they can describe it to you like it happened yesterday. I've seen ladies in their 50s and 60s describing what happened to them as a child age 6 or 7 because the whole event was so traumatic and so horrific. So there are extremes of how of people's experience of it. And these women were very glad to have support in terms of a clinical psychologist that can help them deal with it. Other women don't want to actually remember anything about what happened because they've buried that, it's in the past, and they've got on with their lives, and they actually don't want to be questioned deeply about something that happened that long ago, which they've put behind them. So there's a big variation on the effect it's had on them when they had it and what kind of care they need. Some women find the terminology upsetting, so calling it mutilation rather than cutting, because they don't feel that they have been mutilated. Other women who had terrible experience feel very much that they've been mutilated and it was something that was done against their will that they remember as horrific, so it's quite varied again. And then just to explain, so depending on where you are in the world, your experience would be different, but we see Indonesian ladies who would have had the procedure done in hospital immediately after birth by doctors under anaesthetic, and it's done as a boy is circumcised at birth, so a girl would be circumcised as well, and that's just removal of the prepuce, so the skin covering the clitoris. And so they particularly find the term mutilation quite bizarre and believe it to just be part of the sort of normal way of being, and would happen if they were in Indonesia. It would happen to their children if they were back in Indonesia. So most women who are seen, if they have no sequelae do report that they wouldn't continue the practice on their daughters. But some of them very honestly say, actually, if I was back in my country, my daughter would be circumcised, not particularly because I think it's a good thing to do, but because my entire culture, environment, my parents, my aunts and so on would expect that to happen. And so if we were back there, probably it would. But if I'm here in the UK, I don't feel it's a necessity, an extreme, that she needs to have this done in order to get married. So very varied group of women with a varied various issues, some of which are trivial and some of which are incredibly serious. So that's the end of my talk. It was more really just so that we all had the same understanding of what FGM and FGC is, and introducing Katy, who's actually already been introduced by Kakila, but she's going to come and tell us about her very broad experience across the globe with FGM and FGC.
Morning, thank you. Thank you, and it's great to be invited to speak here. Can everybody hear me okay? If I don't, I tend to wander a little bit. Great. My name's Kati Newell-Jones. I'm not a surgeon. I've been working in health settings for 20 plus years, and I've been working more along the lines of social interactions, why practices happen, and what can we do to stop them. Great to see Tony here, Tony Jeffries, who after many conversations in different places said, why don't I come along and talk. So I've worked in quite a number of countries, including in Somaliland, and quite a lot of my work has been in Somaliland very recently. And so that's the country that I'm going to focus on this morning. So this is really where I've been working at the moment. So since 2015, I've been involved in Somaliland. And with ActionAid and also a small local organisation called Somaliland Family Health Association, and I've been carrying out research. So the research has been a combination of qualitative and quantitative. And as you'll see, we've got a total overall of about 4,000 people who've been interviewed in these two pieces of research, both baseline and midterm reviews, which are happening at the moment. We're just finishing off the final of those midterms at the moment. Somaliland has also been looking at national indicators for FGC. To be thinking about this whole issue, as Anita said, what do we measure? How do we measure? Because it's not easy, and especially once in a country you have a law, which there isn't in Somaliland, you start pootling into communities and asking people whether they're cut or whether they're going to cut their daughters, and people know that that's illegal, then it's quite difficult to get honest responses to that. So they're looking at national and international indicators. And then we've also been I've been facilitating knowledge sharing workshops for the last couple of years in Somaliland, working with all the organisations who are working to end FGC, and also government ministries and community leaders. So that's a little bit of where I am and where I'm coming from. So where is Somaliland? It's that bit on the, so it's part of Somalia. It's an independent state. It declared its independence in 1991. Now, Somalia is one of the countries with the highest rate of FGC. So 98-99% of women and girls are cut in some description or another. And 80%, and these are DHS and mix figures, 80% of those women have had the most severe cut. WHO type 3, as Anita showed you, with all its ramifications. So midterm reviews, if we kind of cut on through, so midterm reviews, which is just these last couple of years, we're talking about the overall prevalence still being 98-99%. So in most communities, most people, most men, most women, most children, don't know someone who hasn't been cut. So if you can imagine being in a culture where everyone is cutting. And one of the things which is really quite scary for me was that after several years of interventions, the young women, ages 12 to 24, the same rate, it was about 97, 98% of 12 to 24-year-olds are cut. Now there's a change so that the type of cut is less, but they're still being cut. So we've got 92% of women interviewed undertook cutting with stitches, still in the midterm review. However, only half of them, 51% of their daughters, had that. So you can see a big shift from 92 to only half of the daughters being cut. So we've got this change in the type of cut. So I won't stop here. There's a whole load of different types and the different terms, Somaliland being an Islamic country, and we've got the kind of zero tolerance, nothing happening over here. You've got type 1, which pre a lot of these recent interventions was what was happening and being called the Sunnah, Sunnah being Islamic cut. And then we've got the intermediate, type 2, type 3, and then type 4, which is coming in, which is a prick. There's been a lot of change. So that's the range of what we've got, okay? And underneath you've also got a range of the type of instruments that are being used, from your traditional cutters to your TBAs to what your nurses, doctors and midwives might be using. So, I come from a body of thinking that thinks of FGC as being a social norm in a community. So it is something which happens because it happens and because it's working within the community. Now, why it's important to think of it as a social norm is that we often, as external people, but also health people or whatever, we go into a community and we think, let's tell people what all the complications are for cutting. And if I tell people that if they cut, then their daughters may have fistula, they may have this, they may have that, they're going to have monthly kidney infections, etc., then if they know that, they'll stop cutting. And that is very much from an individualistic approach to be thinking that if I do that, they'll stop cutting. If we look at it as a social norm, then that's rather different. So in order to be a social norm, there are these 3 conditions. One is that it's valued by a community. And as Anita was saying, and as we've seen in many, many ways, cutting is valued. It's expected of people. If you are cut, you are of a higher status. You're marriageable, you have celebration, you have new clothes, your family can celebrate. So it's very much valued by the community. So if you decide not to cut your daughter, you're going against that. It's also, over on this side, it attracts sanctions and benefits. So people often think, oh no, there's disadvantages to being cut, there can't possibly be advantages to being cut. Well, actually, there's loads of advantages to being cut, even if you're being cut by the most severe cuts, because you're socially acceptable, you're marriageable, etc. Okay? In Somaliland, just recently, when I was last there, I met a young woman who was trying to decide whether or not she was going to cut her daughter. Now, her family has a camel tribe, and she sells the milk. That's the income from the family. Now the local community are saying, if you don't cut your daughter, we won't buy your camel milk. So in terms of sanctions, that's a massive thing for the family. So there's that mother. She's trying to decide, is she going to take an individual decision not to cut her daughter? And if she does, what's that going to have on the whole of the extended family? So, sanctions and benefits. And finally, the third one, interdependency. I cut my daughter because somebody else cuts their daughter, and he expects his daughter to be cut, and so cuts their daughter. And we all have social norms within our community. If we have a lot of eating social norms, we have a lot of, if you catch public transport in the UK, then generally speaking, you get on a tube, a train or a bus, you don't talk to strangers. You keep your eyes down, you don't talk to people in the UK, and that's our social norm. If you start chatting away to people, people start thinking you're a bit loopy. Go somewhere else, and those of you who come from different cultures, you wouldn't think of going on public transport I'm just back from Kenya just recently, wouldn't think of going and getting on in a matatu or a bus without saying hi to a couple of other people on there. So social norms are part of what keep us going. And these social norms are keeping that practice in place. So if we think we can change by just saying, here are the health complications, now stop it, we've actually got to think of a whole load of other things around in order to stop this. Again in Somaliland. So down the bottom here, biggest celebration in my life, just like Anita's picture. When I'm cut, I'll be purified, ready for marriage, and it's a fantastic thing. And that is a lot of what young people, when they're looking forward to it, they might know that it's going to hurt, they might know there might be complications, but it is something which they're looking forward to. Not all by all means, but many. If I'm not, and there you are, that's a positive benefit of being cut. Down the bottom there, you've got a negative one. So you've got the being called names, not being allowed to marry, etc., etc. So all of these issues around there. So it's not an easy decision to decide whether or not to cut. What we've looked at in the research in Somaliland have been all this whole load of things. I'm going to concentrate on medicalisation. I'm also going to talk about decision-making dilemmas as well. So I'm going to concentrate on just on medicalisation because here we are in the global health group. So, medicalisation. Here, what we've got is there's an increase in Somaliland in the medicalisation of cutting. Okay? So when I first went in, people said, oh, it's so small, we don't even need to talk about it. But hang on, it is changing. So here we are, right down the bottom. So we've got the blue is the baseline, so that was, this is Action Aid, so 2018. And the MTR was, the data was collected in 2018 for the midterm review. So way back, the overall women cut by a health professional, yes, it's low, it's less than 10%. However, if we look at women under 25, we've got, so of that group, there's actually a doubling, more or less, of the proportion who are being cut by a health professional. When we ask those people, what about your daughters? What do you, who cut your daughters? You can see a massive change. So of the women in the midterm review, we've got 44% of them saying that when their daughters were cut, and remember, it was still 98, 99% of the daughters being cut, they were being cut by a health professional. Now this is quite shocking, okay? And look at that change, right? And this is the first time that this sort of data has been revealed in Somaliland, and it's influencing the debate, it's influencing policy, it's influencing the Ministry of Health. Once again, and this is, so that was the Action Aid one, this This is SOFA, the lovely name, Somaliland Family Health Association. And this is again for their midterm review. And these are different communities, different regions, Adal, Togdahir and Madodijis. So here we've got the interviewee, her daughter, and her future daughters. Okay. Now you will see a slight, and this is for the midterm review alone. So we're actually up at those higher figures. Now the reason why this is 19% rather than just the 8 or 9 as the last graph was, that this piece of research focused more on younger people. So we've got slightly higher figures. But again, look at that between the interviewee, her daughter, and future daughters. And now we're over the tipping point. We're into 71% of people intending to have their daughters cut by a health professional. So this is a serious issue, and WHO are now involved in some training in 3 countries that I've been working with them on. Their pilot will be in Guinea, in West Africa, in Kenya, and also in Somaliland. And that'll be looking at training of health workers to reduce medicalisation. So, positive perceptions, and this goes back again to our social norms. So in a rural community over in Sanag, only the TBAs, and so this was when they were asked, who does the cutting? I asked them, who does the cutting in your country? Only TBAs and traditional cutters, we don't have anyone else. And it would be much better if we did. Okay, so this is what a community is saying. And down the bottom, again, this is a semi-rural community over on the west. And again, until a few years ago, traditional cutter used to come. Now she doesn't come anymore. Instead, we gather our girls together and we take them to the MCH and we have them cut. So these are communities, and they're saying this proudly, absolutely proudly, that this is what they do. This is what they do in order to, in their opinion, keep their girls safer. Okay, so here, a community facilitator, a wonderful young woman and her nephew, and this was last September. And she is one of the community facilitators on an FGC project. So she is campaigning for the end of cutting, okay? And she says this. So I was there just after the summer holidays, and she was going to take her 3 nieces to a traditional cutter, and then a friend phoned her and said, don't do that, go to the MCH. And interesting things here, she went, and I said to her, did you have to make an appointment? No, I just went along. And she was so proud. The girls were all playing straight away and went to school the next day. They had the type 2 with 2 stitches. So there will have been serious, most likely to be serious complications as the years go on. So one of the other things which is a misconception in Somaliland is that cutting where it's only pricking or snipping only, types 1 and 3, are generally speaking not regarded as being FGM. FGM is considered to be that quite severe, very severe, removal of everything, the type 3. So again, this sort of trend, and kind of posing to you now, what are you thinking now about this as medicalisation? Is this a good move? No, is this a good move? Because when they're going to an MCH and being done there, there's anaesthetic, there's a skilled midwife, and there's often antibiotic as well. Is that better? Is that what we want? So here we are. a nurse interviewed. So this was in a government hospital in a rural community, as I interviewed. So here she goes. I was sadly cut before the community changed from the pharaonic, that's type 3, to the Sunna type of cutting. She's suffered all her life. She's got no children and no grandchildren. And here she is. She uses anaesthetic for the 2 stitches, not for just the prick or the snip. It's more healthy to do it here. It's aseptic, sterile. Okay? When I asked her how she felt about doing this, she said, I feel a lot of happiness because she is doing something to her, the next generation of girls, which is less harmful, in her opinion, than happened to her. Down the bottom, she actually said to me, I need more training on this. I need more training to do it better. Should she get that training? The Ministry of Religious Affairs in Somaliland believes she should. They want to see the cutting, just performance of the sunnah, a snip or a prick, introduced into the midwifery curriculum. Anita, when she introduced these this morning, said definition of FGC is intervention with girls' genitalia where there is no medical reason. Should it be in the midwifery curriculum? Defibrillation definitely should, but should cutting? So can you see here, is she a heroine or is she a villain? And once a law comes in, which isn't going to happen for a long while, I don't think, in Somaliland, then what's going to happen then? So here we are again, right. So this is now February this year, and interviewing health professionals. And remember, this is new data for Somaliland. This is, so here, what we've got here is of the health professionals that were interviewed in the midterm review, 28% of them have been approached by someone asking them to cut their daughter. Okay. On the other side, how many of them? 22% of them said, yes, I've cut. I have performed some kind of a cut. And then the bit that really kind of concerns me is of those, 3/4 of those have actually cut with stitches. So they have performed type 2 or type 3. This is, now we have draft anti-medicalisation strategy that's been developed by MOH at the moment, and it is enormously contested here. Is the anti-medicalisation strategy trying to stop people doing it with stitches or not? Is it trying to do it safely? So there's a whole load of issues around here. Yeah, again, just up the top there, from the surveys again, from the research, 70% of health specialists intend to cut their own daughters. 70%. And all of those would use a health specialist. Okay? And 80% of health specialists would expect their sons to marry a cut girl. All the advantages again that Anita mentioned about that. So these are your health professionals that you're working with there, and they are subject to those social norms that we've talked about in their communities. One other midwife again. So she has open girls again for marriage. She campaigns for what she calls zero tolerance. However, when I asked her at the end, I said, there's a kind of contradiction here. You're campaigning for zero tolerance, but yet you're performing it. And she says, one's what I have to do as a midwife, and the other is what I hope for in my community in the future. So this again, health professionals and parents, but we're talking just about health professionals here, having decision-making dilemmas. It's all well and good for us to say, here's the medical evidence that you shouldn't do this. Actually, they're part of the community, and so they have all the social pressures as well. And in a rural community, that's quite significant. So, in summary then, medicalisations, it's happening, it's increasing, and it's highly contested. Some people in the Ministry of Education support medicalisation because they say we're not going to get abandonment, total abandonment. At least if girls just go and have the sunnah done in an MCH, they will be back at school, their schooling will be interrupted less. So education is important, let's medicalise cutting, and then it won't interrupt with people's education so much. Medicalisation is obviously opposed by WHO and a lot of internationals. It's opposed publicly by most of the ministries. The Ministry of Religious Affairs supports it, and they want to see training of health professionals. It's supported by some within Ministry of Education and Health. And at this point here, as you've seen from the quotes, is actively sought by most community members. And so really thinking about harm reduction through anti-medicalisation won't necessarily lead to that abandonment of everything. So really that's where I want to leave you. Health professionals facing decision-making dilemmas that are brought about through their own social norms in the communities. And so it's not that easy to make decisions just based on health complications as we might imagine it to be. There's a whole load of other things going on there. WHO, as I say, are doing some interventions that are starting in Somaliland shortly. And so far, their health clinics are doing some amazing work with their midwives and nurses to counsel people rather than fall into the trap of doing the cutting. And that's really where we are at the moment. Anti-medicalisation versus training midwives, and that is part of the big public debate that's going on in Somaliland. I wonder which side of that you might sit. Thank you.